and I'm a new summer intern at Stanford's Palliative Care Center of Excellence, and we feel very fortunate to be co-hosting this event today with Hospice of Santa Cruz County. We hope this presentation will give you a better understanding of both palliative care and hospice. And if you haven't already, please click on the interpretation button on your Zoom menu and select the English or Spanish channel to listen to this presentation in your preferred language. As we get settled in and started, let me tell you guys about the Stanford Palliative Care Centers of Excellence's mission. So our mission is to raise awareness of palliative care among our communities through community outreach, partnerships, and by providing free educational events to the public and healthcare providers. And to talk about a little bit about Hospice of Santa Cruz County, they are the leading nonprofit provider of hospice care in Santa Cruz County. The hospice program is enriched by community grief support, a children's bereavement camp, transitional care, and palliative care services, as well as concurrent care for children, pet companion, music therapy programs, and as well as care for veterans and end-of-life education and outreach. Now that we've talked a little about Hospice Santa Cruz County and Stanford's Palliative Care Center of Excellence, I'd like to introduce our presenters. So we start off with Monica Newitt. She serves as the patient care manager for Hospice of Santa Cruz County's Transitional and Palliative Care Program, as well as the Concurrent Care for Children program. Monica is well-versed in the specialty of providing in-home comfort care with dignity, honoring patient and family values. She also holds a Bachelor of Science in Nursing from Southern Cross University in New South Wales, Australia, and is a certified hospice and palliative care nurse. Monica is very passionate and dedicated to serving individuals and families living with life-limiting illness. She has worked in the hospice and palliative care field for 10 years. And this leads into our next presenter, Dr. Grant Smith. He is a palliative care physician at Stanford and the medical director of the Palliative Care Center of Excellence. He provides direct patient care while pursuing his academic and educational interests, improving patient-centered care across settings, as well as increasing access to palliative care and promoting clinician well-being. Originally from Knoxville, Tennessee, he received his medical degree from Harvard Medical School and completed residency in internal medicine, and as well as a palliative care fellowship at the University of California, San Francisco. He is very passionate about educating communities who have faced historical injustices about palliative care and increasing their access to it. And thanks again to Dr. Smith and Monica. And with that, I'll let them take it away.
Thank you so much, Jessica, for that warm welcome. Really appreciate that.
Of course, thank you.
And welcome to everyone who's joined us. Again, we're so grateful for your time and we're hopeful that this session will be helpful for you. Just a few reminders. As Jessica mentioned, make sure that you click on the interpretation button and click English or Spanish to join the channel that's appropriate for you. We're very grateful for our Spanish interpreters live interpreting for us today. Thank you so much. We imagine that lots of questions may come up during the presentation today, and we really want to make sure that we answer those. To ask a question, click on the Q&A box on the bottom of your screen. It will open up this dialog box that you can see here. You can type your question, and you can even send your question in anonymously by clicking the Send Anonymous button, and then click Send, and that will send the question to us as well as to other attendees on the webinar. Today, we won't be using the raise hand button, so if you see that, don't click on that because we won't be using that. For those of you who have questions, you can open this question and answer dialog box. And as individuals and attendees ask questions, you'll be able to see them. And you can actually vote for a question by clicking the thumbs up icon. This will help us to see the questions that are most popular, and we'll make sure that we try to answer those first. So feel free to ask your questions and vote for the ones that you think are most important to you. For a roadmap today, we'll be talking about an overview first of palliative care, and then we'll be talking about hospice care. We'll highlight the differences between palliative care and hospice care, and then we'll also save time to get to those questions. So I want to start by having everyone here just think about what comes to mind when you hear the word palliative care. As you're thinking about that, I'll just share this picture, which is a screenshot of what happens when you Google image search the word palliative care. And if we are to believe Google, it would suggest that palliative care is about having what looks like a younger person holding an older person's hand. And unfortunately, these pictures make it look like this is only for white people. And so I hope that by the end of the conversation today, that we're able to tell you that palliative care is able to do much more than just hold someone's hand, although we're happy to do that. And that we really want our services, both for palliative care and hospice, to be available to the rich diversity of patients who live in our area. A really common question that we get is, how are palliative care and hospice different from my other medical care? What I would say is that both for palliative care and hospice, we have a bit of a different philosophy. And that starts with seeing the person beyond the disease. And what I mean by that is that we think about the people that we're serving as people who might be living with an illness or living with cancer, rather than a cancer patient or a heart failure patient. And while this is a sort of turn of phrase, I do think that it reflects the overall philosophy and perspective we take. We're trying to take care, we are people taking care of people and doing the best we can to help them. Another way that palliative care and hospice are different is that we take a holistic approach. And what I mean by that is that we know that a difficult illness, whether that's a cancer, heart failure, lung disease, whatever it may be, affects not just the body, but it can affect the mind, like psychological or stress, can affect the spirit, and can affect practical aspects of life. And so we try to take a step back and not just focus on the body, but at the whole picture of a person. So what's happening and how is this illness affecting you as an individual and as a person, part of a family? You can see that we mentioned family here, and that can extend to family, friends, caregivers, or whoever is important to the individual we're caring for. And we really see that whole unit as who we're trying to care for. This perspective is true both for palliative care and for hospice. With that, I'm going to transition to talk a little bit more about the specifics of palliative care. And then later in the hour, Monica will be talking more about the specifics of hospice. So let's talk about who's on your palliative care team. And there's multiple people, and that's meant to have all those different people so that we can address all those different aspects of life that we're hoping to care for. So you may meet with a doctor or a nurse, a social worker, and a chaplain can also be part of the team. As a doctor and Monica as a nurse, we're often helping to prescribe medications, help with medical decisions, and coordinate with the other doctors involved in care. Our social workers can help provide emotional support, support to caregivers and family members, help with seeing if we can get needed medical equipment, and address financial concerns. Our chaplains are available to provide spiritual support, to help answer some of those difficult questions, like, why is this happening to me? Or how do I make meaning out of all this? And they can often also offer prayers and blessings. I've told you a bit about the team that you may meet with palliative care. I'd next like to provide a standard definition of palliative care to give you a little bit more information, and then we'll take time to dive into the definition a bit more. So palliative care is specialized healthcare for people living with a serious illness. It focuses on providing relief from the symptoms and the stress of the illness. The goal is to improve quality of life for both the patient and the family. This next point is really important for palliative care, and it's that palliative care can be appropriate at any age and at any point in a serious illness, and absolutely can be provided alongside curative treatment or treatments that are meant to address the underlying illness or even cure that illness. Many people wonder, well, what diagnoses can be eligible for palliative care? And what I'd say is that we've used this term serious illness, and it's a broad term. I think of a serious illness as any illness that has the possibility of being life-limiting and potentially life-limiting over the course of several years. Some of the very common diagnoses we see in our clinics include cancer, heart failure, or end-stage disease of other organs like liver, kidney, or lung. We help with individuals who are living with dementia or other neurologic illnesses like ALS or Lou Gehrig's disease, Parkinson's disease. We can also be helpful for individuals who maybe are just getting hospitalized frequently, even though there may not be one of these particular illnesses, or they're having what we would call functional decline, meaning that they're able to do less physically than they used to be, or that they need help for more and more activities that are part of just daily living, like getting dressed or eating or bathing. These are all times when it would be very reasonable to meet with a palliative care provider. I mentioned that we help provide relief from the symptoms and stress of an illness. And this is a list of some of the common topics and issues that we're helping people address when we see them: pain, shortness of breath, nausea, constipation, psychological symptoms like anxiety or depression, or even just coping with an illness or new news or difficult news, fatigue, poor appetite or weight loss, neuropathy, which is that kind of tingling pain that some people can get in their fingers and feet. And we're also here to support caregivers. We know that caregiving is sometimes a thankless job that can come with a lot of stress. We're there to also support caregivers. In addition to helping to manage these sometimes difficult symptoms, we also can help with medical decision-making. This can include things like advanced healthcare planning, which is sort of an umbrella term that includes things like conversations with your family about the types of medical care you might want in the future if you were to get more sick. It can include assigning a person who would be able to step in to make medical decisions for you if you weren't able to do so. Sometimes that advanced care planning includes completing documents like an advance directive, sometimes also called a living will. We also can help weigh different treatment options. I think of an example of a patient I saw recently who has lung cancer, and that lung cancer has spread to other parts of his body. He's trying to decide if he should go to have more chemotherapy treatment or not. And I'm helping him just to think through how he's weighing that possibility that the treatment might offer him more time against the possibility that he may have difficult side effects from that treatment. And so we're spending time together talking about what's important to him, how he thinks about time, how he thinks about quality of life. And even if there are questions that I may not be able to answer, I can serve as an advocate for him with his other doctors to help ask some of those difficult questions that maybe it's hard for him to ask, or something that I'm not sure about myself. So we can help coordinate between providers as well. There have been many studies that have looked at, does palliative care actually help people? When people see a palliative care team, what are the benefits? And many studies have shown that working with palliative care can lead to an improved quality of life, better control of difficult symptoms, improved spiritual and emotional well-being, greater satisfaction with care, even sometimes fewer hospitalizations, and less burden on caregivers. Monica and I wanted to provide a little bit more description about what palliative care can look like. There is some variability between one palliative care program and the next. And I think that actually Stanford's program and Hospice of Santa Cruz palliative care program are nice examples of ways that they can be different and ways that they're similar. At Stanford, our palliative care program can help support patients who are hospitalized. We call that inpatient palliative care for patients who are in the hospital. And then we also provide what we would call clinic-based or outpatient palliative care. That means that patients come into our clinic either physically or now virtually through telehealth to see our palliative care team, which again can be a doctor, including a nurse, or including a social worker and a chaplain. These visits can be changed in frequency depending on patients' needs. As an example, I recently saw a patient who I met about a year ago. When I met this person a year ago, they were having a lot of pain. I needed to see this person every week to make sure I was getting their pain under better control. After a few weeks, their treatment actually really started to work and they got a whole lot better. They actually didn't need me anymore. I didn't see them for a year. Unfortunately, their cancer ended up progressing down the road and they just contacted me and they needed to see me again to help with their pain. So we're able to sort of titrate or adjust the amount and frequency that we see patients depending on what their needs are. Again, these services are provided primarily either in a clinic visit or through telehealth. I'm going to pass the mic over to Monica so she can talk more about Santa Cruz, Hospice of Santa Cruz's palliative care program, which is a little bit different.
Good morning, and thank you, Grant. Welcome, everyone. I just haven't had a moment to say good mornings, and I'll start telling you about our community-based palliative care program here over at Hospice of Santa Cruz County. As Grant mentioned before, he's providing palliative care in that clinic-based setting, and we are meeting patients and families where they are at their home, in a facility, really trying to do what we can to meet them in a setting that is most comfortable and convenient for them. Our visit frequency is a little bit different. We aim to see patients every 4 to 6 weeks, and we titrate that depending on the acuity and the symptom management needs that our individual patients and families are having. And we provide those visits across many different settings or avenues, excuse me. We can do that through an extended telephone call, a video visit, or we may meet the patient and family at their home setting, whether again, that be in a facility or at their home. So one of the first questions that comes up is who pays for this specialty services? And it is paid for by most insurance plans based on your diagnosis and your needs. And specifically, our program will work with you to find a way for us to be able to provide care for you and your loved ones. So how do you access palliative care? The first step is to ask for a referral from your primary care provider or a specialist, much like the cardiologist or the oncologist. In an inpatient or hospital-based setting, including the emergency room, you may also ask for a referral, and the care team there at the hospital will help guide you to your local resources or providers. And, I'll say that many of my healthcare colleagues are still learning about palliative care, what it means, what specialized services and resources we offer. And sometimes very well intended physicians may still confuse palliative care with just being end-of-life care. If you ever meet a resistance when asking for a palliative care referral, please, we empower you and encourage you to insist that you would like to speak with a palliative care team for help with decision-making and support. So palliative care and hospice are not synonymous, although unfortunately many well-meaning and educated healthcare providers and community members will mistakenly use them interchangeably. As Dr. Smith has highlighted so well, that palliative care is a large and broad field focused on pain and symptom management and helping make sure that the care plan is focused on what matters most to patients. Again, palliative care is for patients at any stage, at any age, and can be included while seeking curative treatment. Hospice is a specialized type of palliative care that is designed specifically to support patients at the end of life, within the last 6 months of life. And hospice is under the larger umbrella of palliative care. Similar to palliative care, hospice focuses on quality of life. As a philosophy of care, hospice focuses on supporting patients for whom comfort and quality of life is the highest priority. Specifically, hospice care is designed to support someone in the last 6 months of their life. Unlike palliative care, hospice is provided for patients who have decided to forego curative treatments, and the goal of their medical care is reframed to focus on comfort, not curing the disease. In providing this type of care, hospice typically thinks about every intervention or medicine and asks the question, does this help make the patient more comfortable? If it does, hospice does everything we can to try to make that thing happen, or that intervention, And if it doesn't, we'll recommend stopping that treatment or just redefine their goals of care. Again, the philosophy of hospice is a really good fit for patients who want quality of life and comfort to be their #1 priority, which often includes patients that are less focused on pursuing interventions that might prolong life. As a philosophy, hospice also aims to support patients and families being in the place that is most comfortable to them, wherever patients call home. This typically is at a person's home, but can also be a skilled nursing facility, a residential care home, assisted living, or in rare cases, a hospice house, which is a specialty facility where hospice services are provided, like at Mission Hospice in the Peninsula. We do our best to meet patients and families where they are at in any setting. Hospice provides an interdisciplinary team similar to palliative care, but with even more roles that typically include a physician, a nurse case manager, a social worker, a spiritual care coordinator, home health aides, and a robust volunteer program, often including companionship, pet therapy, massage therapy, grocery shopping, and really things that help focus on improving the quality of life. As mentioned before, hospice is not a place, and this is a service that can be delivered anywhere the patient calls home. Hospice has the ability to help a patient and family move their loved ones to a new setting if you or if your loved one needs a higher level of care. And it's not uncommon that someone will come onto service with hospice, and over time their care needs may increase, and that the care needs may exceed that of the family's capacity. And that patient may need 24/7 nursing staff. And so hospice can help facilitate that move to a facility in which that level of care is provided simultaneously while remaining on hospice services and likely with the same team. Another enormous benefit of hospice is that it provides you access to a nurse 24/7. And this nurse is available by phone and tries to help manage your symptom needs over the phone. And if those needs cannot be met over the phone, then typically a nurse is sent out, whether that be at 12 o'clock in the night or 7 o'clock in the morning or 2 o'clock in the afternoon. We really try to aim just to meet your needs as quickly as possible. Hospice also takes responsibility for prescribing all of your medications. They often work closely with pharmacies that deliver and can have a quick turnaround time in getting medications to your door. We also provide medical equipment, including things like a hospital bed, a bath chair, a wheelchair, delivered right to your door. And one important thing to note about hospice is that we do not provide 24-hour caregiving for personal care needs, like bathing, getting changed, or showering in the middle of the night. Family and friends are responsible for providing that 24/7 level of caregiving needs. However, if your care needs are not being met or exceed the need of your family and friends, the hospice social worker can work with you to help find local caregiving resources. So as Dr. Smith previously mentioned, the holistic approach, hospice focuses the entire family during the care. The hospice team develops a plan of care that meets each patient's individual needs for pain and symptom management. The care team usually consists of the patient's personal physician, that community physician who you've known for a long time. We don't like to cut them out. We like to still keep them in the loop and work in collaboration with them. We also have our medical director that oversees the hospice plan of care. We have a nurse that visits, the home health aides, the social workers, the counselors, the volunteers. And for some instances, we do offer some therapy services. And that's really focused on keeping the patient safe in the home-based setting. Next slide, Grant. Thank you. So maybe you're wondering who pays for hospice. It's covered nationwide by Medicare, and in California, Medi-Cal. And most private insurances do have a hospice benefit option available. Non-for-profit hospices like Hospice of Santa Cruz County also provide philanthropy level of hospice care that is for patients not covered by insurance. Patients must have a 6-month or less estimated prognosis and be eligible to receive hospice benefits. The hospice organizations will continue to recertify patients to confirm that the patient has a prognosis of 6 months or less. And if that prognosis change, they may be discharged from service, but can come back on at a later date. Sometimes people like to know, can hospice, again, if they get discharged and if they have a decline again, can they come back on service? And that might be in 6 months' time, that might be a year later, that could be 2 weeks later. If you have a question, we always encourage you to pick up the phone and give a call. So how do we access hospice care? You can access it at any time. A patient and family should feel empowered to discuss hospice care with their primary care physician or any healthcare provider in the patient's care. You do not need to wait for your physician if you feel you have an urgent need and your loved one does not want to return to the hospital. You may pick up the phone and call your local hospice, and they should have a 24-hour answering service, which may be able to help guide you to getting you on service as soon as possible. There are many different hospice providers in our area, across both settings in the Bay Area and here on the Central Coast. Some of them are much like the organization that I work for, which are nonprofit, Hospice of Santa Cruz County or Mission Hospice in San Mateo County, and others are for-profit organizations. We really encourage you to go to the Care Compare website to view the hospices that are available in your area and how they are ranked by patients and families just like you who have received their care. And this survey is really based off of Medicare guidelines, and patients and families answer these questions and complete these surveys at their own will, at their own time, and with their own opinions. So we really encourage you to go there to look for the nearest hospice provider to you. And then now I'll hand it back to Dr. Smith.
Thank you so much, Monica. That was excellent and just great to hear all that updated information about hospice services. We just have a few more slides left to present before we get to our question and answer portion. So I just wanted to remind everyone, please continue to put your questions in the Q&A. And I believe now that you should see that thumbs up icon. So if you see other individuals' questions that you think would be interesting to have answered, feel free to click that thumbs up icon so you can vote for that question. And then we will try to get to those questions. Well, we've spent some time talking about palliative care and hospice, and this is a summary slide that tries to put some of that information together. And in this Venn diagram, you can see that the shared areas between palliative care and hospice is this focus on optimizing comfort, reducing the stress and symptoms of an illness, working as an interdisciplinary team. You heard about some common threads of chaplaincy, social work, doctors, nurses, and other individuals who are all part of the care team. And then, as we mentioned at the very beginning of the presentation, that holistic picture is the perspective that both palliative care and hospice take to provide care for a patient and family. To highlight a few of the differences, remember that palliative care can be received at any stage of a serious illness, while hospice care is really for individuals whose prognosis is estimated to be 6 months or less. Palliative care can occur alongside curative treatment or other treatments targeting the underlying illness, while in most cases, hospice care, individuals are not pursuing curative treatment. Palliative care typically can occur in the hospital or clinic, although sometimes can occur where someone lives, like in their home, as Monica described. Hospice care is overwhelmingly primarily provided in someone's home, but again, as Monica mentioned, can take place in other places wherever the person identifies home as. And another great benefit of hospice care is ongoing grief support. As we wrap up, we just want to provide some additional resources for more information about palliative care and hospice. Our Stanford team has a website all about palliative care. There's a site for patients and families that includes a lot of the information we discussed today. Hospice of Santa Cruz's website also has information about their services and how to contact them. And also the National Hospice and Palliative Care Organization is another great resource for additional information. With that, I just want to thank everyone who's on this webinar for their time and interest. And I can see we've got quite a few questions in the Q&A section, so we're really excited to get to this. I'm going to pass the mic over to Pilar, who will help to facilitate our Q&A portion. And Monica and I will be helping to field these questions as well. Thank you so much, Pilar.
Thank you, Dr. Smith and Monica, for sharing with us today. If you have a question, please type in the question and answers box. If we are unable to respond to any remaining questions due to time constraint, we will be happy to follow up with an email response. So we have a couple of questions in here, and Dr. Monica can answer. And this question asks if in the Santa Cruz area, please explain how PANF and Solar Health Hospital versus Dignity and Dominican Hospital handle palliative care. Do we know that?
Yeah, thank you for the question. So I am familiar with PANF, and they operate very similar to Hospice of Santa Cruz County and their palliative care team. The difference between us is that we really try to have the PANF physicians stay within the PANF palliative care team. And then we work with our organizations works with Dignity to provide a home-based palliative care program for their patients. And then Kaiser has their own palliative care program. They do not, to my knowledge, have a community-based service that is clinic-based service. So their palliative care would be similar to what Grant has explained he provides in his clinic.
Thank you. Thank you, Monica. Doctor, you have anything to add, or we can move to the next question?
We'll just add that I do think that the Bay Area is rich in palliative care resources, all the way from, we've talked about sort of Santa Cruz, San Jose. The East Bay has a growing palliative care presence all the way up into Marin and beyond. So we're very fortunate to have good palliative care and hospice services in the Bay Area.
Great. Another question that we have is from someone who wants to edit the Advanced Healthcare Directive to ask for palliative care and hospice when appropriate. And the question is, it is legal for this person to use a word process page as the addendum to the Advanced Healthcare Directive rather than writing on the form? Is physically painful and mentally challenging for this person to rewrite the whole form each time she needs to edit it. I would like word process all information and instructions and handwrite on the form something like see word process document addendum. Her doctor or his doctor did not know if this will be legally binding. Do you have any idea how a person can add information to the Advanced Healthcare Directive?
I'm happy to answer this one, and Monica, feel free to jump in too. It's a great question, Willow, and I think as a physician, I would be happy to see what you've had typed up. And our goal is really to get a sense of what people's wishes are, and if that's in a typed document versus a advanced directive form or written on it, both those methods are very helpful for us. The question you're asking about, is it legally binding? I'm also not sure about. I believe I have seen advanced directives that have an extra sheet of paper attached where people outlined their additional information. So my general sense is that that would be okay, but I'm not sure about sort of the legally binding component of your question. Just I haven't seen that scenario come up before. I'm not sure, Monica, if you have other thoughts about that, but just haven't seen that exact scenario.
Yeah, my only comment would be this would be the time where we would really focus on using that interdisciplinary model and pull our social workers in to help guide a patient and family through this question.
There are community agencies providing workshops in healthcare directives, so probably that will be a good resource. We have a very interesting question in here, and it says, do we know the percentages of people approaching this kind of services, counting, for example, LGBTQI or Latinos, people of color, immigrants?
I'm also happy to take a first stab at this one. And I'll just say thank you for asking this question. We know that that people of color are less likely to access both palliative care and hospice services. And this is an inequity that I know that our team and Hospice of Santa Cruz very much want to address. And as part of actually why we're having this webinar and why we're so grateful for our Spanish interpreters to help increase access to information about palliative care and hospice. So this is an enormous place where the field of palliative care and hospice has a lot of work to do. So we do have information, and we know that the communities you mentioned are traditionally underserved by palliative care and hospice. So thank you. And yes, we very much want to be in the community, telling these groups about our services, helping get people access to these services. So thank you again for your question.
Thank you, Doctor. Next question is, the term comfort care is used often in the hospital setting. Is comfort care the same as hospice?
I'll take this one, Dr. Smith. Thank you. So comfort care is not the same as hospice. As we've highlighted throughout this webinar, that the term palliative care is very broad, and comfort care is included under that umbrella of palliative care. So again, remembering that hospice aims to focus on those with a life expectancy of 6 months or less. And in the meantime, if you do not have that diagnosis or prognosis, palliative care, we still focus on comfort, and we really aim to provide comfort care based off of the individual family values and goals.
Thank you, Monica.
I may just add to that too, that I think of comfort care as a little bit of sometimes a confusing term because different people may use it in different ways. So if someone is asking you if you want comfort care, you may want to ask them back to explain a little bit more of what they mean by that. So I just wanted to add that one point, that it can sometimes be confusing to know what people mean by that term, and it doesn't have a strict standard definition, at least from our palliative care and hospice perspective.
Thank you for clarifying.
Thank you. Another question here is asking, is there a limit on how long a person can receive palliative care?
I can take that one. And the answer, Grace, to that is that no, there's not a limit for how long someone can receive palliative care. Just thinking back to the story I shared about the patient I was seeing who I met over a year ago, and we just met for maybe a few months, and then that patient didn't need my services. Their symptoms were well managed. They didn't have big medical decisions they were facing. And so I didn't see them for a whole year until they reached out and felt like they needed some additional help. And most of my colleagues in palliative care feel very similarly. We're happy to be involved as long as someone is getting benefit from our services. We can sign off if we're not needed anymore, and we can jump back into the case if we're needed down the road.
Thank you. Do you feel hospice will start using end-of-life doulas, and why do they not utilize them now?
Yeah, there are many hospices currently utilizing end-of-life doulas. At the moment, the agency that I work for does not, but it is something that we are further exploring. So I think that you'll just have to check with your local provider to see if they are offering those services.
Thank you. Another question says that this person is not sure if an average person in the street understand the term palliative and hospice, that especially in Spanish people misunderstand it a lot. Are there any campaigns on the way about awareness?
I can take a stab at that one. We actually know from really recent research that about 70% of adults in the United States have never heard of the word palliative care. That word has zero meaning to them, and that includes a lot of English speakers. So I, again, really agree that this is an area that needs some additional attention. There have been several public campaigns for the general population, not necessarily targeting Spanish speakers that I'm aware of. getpalliativecare.org is one of those campaigns. Another resource is something called the Conversation Project that focuses on advanced care planning and making healthcare decisions. Those are the two major national campaigns sort of in this space that I'm aware of. But I would agree with what I think your question is also suggesting, that there is a large need for awareness campaigns. We hope, along with Hospice of Santa Cruz, that some of the efforts to do webinars and to recruit all of you on the webinar to be sort of agents to go out into the world and let people know how you spent your lunch hour today and to spread the word of mouth. But I appreciate the sentiment here about larger campaigns.
Thank you, Doctor. I can add a little bit to that. Hospice of Santa Cruz County has a Latino outreach project, and we are working on it. So please stay tuned. Another question is asking, once palliative care sees a patient, I assume palliative care will refer patient to hospice when the right time comes. Is this right?
Briefly, I'll just say yes, that our goal is to help you understand what your goals are. And like Monica eloquently described, if that focus on comfort and quality of life is rising up to be that #1 priority, we'll help to get you connected to one of the many Bay Area hospices. And we see that as part of our job.
We have another question in here asking about insurance. What happens if with limitation in insurance? This person wants to know if insurance denies, do you refer them to another source?
This is a great question, and really most insurance plans should be covering palliative care. And if you ran into an issue from Stanford Palliative Care, it would be good to ask your insurance company what palliative care program they contract with. If there are issues, I think we are going to provide a phone number shortly for where you can call. And we do want to help people find access to services. So if that's an issue, we can get information about how to reach out to us.
Okay, here's another question for you, Dr. Smith. And this person says, Dr. Smith, you say that at any point patient can be referred, but it's difficult to make a decision when to refer our decompensated liver cirrhosis patient. Based on your experience, could you recommend the best time for referral to palliative care?
Yeah, thank you so much for this question. And I think this often comes up. It can sometimes feel like, oh, it's too early to refer to palliative care. And I think from our perspective is that we feel like we can be able to sort of help sort out how frequently we need to see someone. At least speaking from our Stanford palliative care team, if you refer someone and we have a one-time consult and we kind of decide, well, things are going okay, maybe there aren't a lot of ways that we could be helpful, then that patient still is connected to us, and down the road, they would be able to get back in touch with us. So those types of consults and referrals do not bother us at all. We can almost always find a place where we can try to be helpful or to help someone start thinking about advanced healthcare planning. I think some clear triggers for referrals in the specific situation of end-stage liver disease is for individuals who are not going to be able to get a transplant. So individuals who, for whatever reason, they're not transplant eligible, those individuals, I think, definitely would benefit from a palliative care referral to start doing some planning, and almost always there's room for symptom management. So I know that's a little bit of a vague answer, but I think there's some clarity about some situations, I think very clearly would benefit from palliative care.
Thank you, Doctor. We are at 12:54 and we have a few more questions. So I'm going to move to the next one. This person is asking, if the patient and family disagree on treatment or care, whose wishes would you follow?
Go ahead. I'll let you take this one, Grant. Sorry.
Okay.
Yeah, thank you.
If the patient and family disagree on treatment and care, whose wishes would you follow? In the United States, I think we have a pretty high value of patient autonomy. And so we would be looking to the patient sort of as the primary decision maker. And so that, we really have patients drive the ship for medical decision making up until the point if they're no longer able to make decisions. And that's when we look for a surrogate decision maker that often is a family member, but doesn't have to be. A really good reason to do advanced care planning and assigning that surrogate decision maker ahead of time is if you're worried that a family member may not represent your wishes, you want to make sure that you've assigned someone and that your healthcare providers know who that person would be who is going to represent your wishes. And having that filled out ahead of time is really important if you're worried that there's going to be disagreement among family members or a close family member wouldn't represent your wishes.
Thank you. Another question says, thanks for this info and all you work closely with pets, palliative, to transition when a patient turns 18 or ages out of 21.
Thank you, Susan. I was let Dr. Smith take the first question so I could take this one. Yes, so here at Hospice of Santa Cruz County, we have our pediatric program is called Concurrent Care for Children. And that's another really unclear term used within the palliative care world. And basically what that means is that children from the age of birth up to 21 can simultaneously seek curative treatment and receive comfort-based home care. And so that's where we come in, and we do offer that comfort-based home care. And it's really a combination of the two services, both palliative and hospice. And again, that the concurrent care benefit serves children up to the age of 21. And then when and if a child or young adult lives beyond that prognosis, then of course they would be welcomed into palliative care here at Hospice of Santa Cruz County or our adult hospice program. And I know that Lucille Packard also has their own inpatient palliative care program, much like Dr. Smith has described at Stanford with their adult palliative care based program.
Thank you, Monica. We are 12:57. What about immigrants with no legal papers? What is their situation regarding these services?
Yeah, I will say that we provide services to all patients in need, irregard of their immigration status or otherwise.
Thank you. And this person would like to know who decides eligibility for palliative care.
I can take this one. And in some ways, it's a bit of a joint decision, often between a patient and family and their provider. There's no, from our perspective, there's not a strict eligibility criteria. So for an individual to have a conversation with their primary care doctor or other specialist about asking for a referral is one perspective. There are some insurance plans, specifically Medi-Cal, that does have some more strict criteria about certain diagnoses where palliative care services are covered. There can be exceptions and there can be applications for a prior authorization or an exception to that. So I would say in general, it's a decision that's often made about when to seek palliative care between a patient and their provider. And then sometimes there can be the secondary component of checking with the insurance provider to make sure that it would be covered. But if it's not covered, often there are workarounds for that too, and to apply and ask for special coverage of a visit.
Thank you. Dr. Monica, this person is asking if the rules for palliative care and hospice are the same for Medicare clients in all states.
I'm sorry, Pilar, may you repeat that question? I'm not
Yes.
seeing it on the list.
If the rules or the regulations for Medicare are the same in all states.
Yeah, for Medicare, the hospice benefit is consistent across the United States, across the nation. Palliative care is going to, with Medi-Cal, is going to be dependent on the individual state and county.
Thank you. This person would like to know if the family says you have mental health issues and there is no advanced care directive, do they care over your decision? Thanks for all you do, Monica and Grant. And thank you, Claire, for inviting. This is from a person who has a contact, obviously, previous to the team. But that's important, when mental health issues, what is the thing to do?
I can take that question. And I think when we're working with an individual who's facing a medical decision that they need to make, one of the first questions we want to make sure about is that individual able to make a medical decision? And there's a few criteria that we look for in knowing if someone can make a medical decision. It includes things like being able to say back what the medical decision is, to say back what the different options are, and to say back what the consequences of different options would be. We call that in medicine, does the patient have capacity to make a decision? And if someone has capacity to make decisions, similar to what I mentioned before, is that in general, we really want to follow what the patient is telling us they want to do. If someone doesn't have capacity for whatever reason, either they're unconscious, not able to communicate, or they're suffering from a state where they're significantly confused and can't understand information, I think a more rare case that you mentioned is if they have a severe mental health issue or a mental health crisis where they're not able to manipulate information, understand information. We would look for that surrogate decision maker to help make a decision on that person's behalf. That typically is done after an independent assessment from the medical team about whether or not the individual has capacity.
Thank you. Thank you so much, Dr. Grant and Monica. We are already 1:02 and over time. So we need to end this session. We would like to thank everybody who attended and participate in this webinar. And I'm going to give out 2 phone numbers where if you didn't get your question answered, please contact us and Stanford, and then we will be happy to talk to you. The phone number for Stanford is 650-723-4000. Again, Stanford, 650-723-4000. The phone number for Hospice of Santa Cruz County, 831-430-3000. Again, Hospice of Santa Cruz County, 831-430-3000. Thank you so much to everyone. Do you have anything to add, Doctor or Monica?
I'll just thank everyone again for coming. You asked great questions, and thank you to Hospice of Santa Cruz and our interpreter team. Thank you, thank you.
I'll second everything Grant said. Thank you, everyone.
See you, everybody, next time. Thank you.
Bye-bye.